Okay, sorry about that. I obviously had the wrong title slide up. Evening, everyone, and welcome to the elbow, wrist, and hand tendinopathy talk. Thanks for joining us this evening. This will be our last talk for the 3 months. We concluded we'll take a break for the summer, and our goal is to do mini-series in the fall to help and continue everyone's education, depending on where things are at. As everyone knows, on a weekly basis, we're also doing the pediatric orthopedic webinars, and tonight's topic will be tumor. They will be discussing upper extremity tumors, particularly bony lesions as well as soft tissue lesions. And there's the password for that. So tonight we have, again, another internationally recognized faculty that will be discussing these topics. We'll start with Jason Nydick down in Florida, who will talk to us about trigger digits. Nash Naam from Illinois will discuss the de Quervain's disease intersection syndrome. Meredith Osterman from the Philadelphia Hand and Shoulder Center will discuss wrist-formed tendinopathies. Tom Hughes from University of Pittsburgh will discuss biceps tendinitis and rupture. And we'll conclude this evening with a shoulder elbow surgeon, Mohit Gilotra, my partner from University of Maryland, who will discuss medial and lateral spondylitis. So thank you all for joining us, and thank you to our faculty for their time this evening. And I'm going to stop sharing and turn things over to Jason to start us off on trigger digits.
Okay. Thanks, Josh, for the intro, and we'll get things started here. So trigger finger, trigger thumb is a very common problem. As everybody's aware, it's something that we all kind of routinely see and almost know what it is before we even walk in the room. For those of you who are out there who are not aware of this problem, anatomically, the flexor tendons get caught at the A1 pulley, whether it be the finger or the thumb, and patients complain of catching or locking or pain over that location. So they can involve any finger. They mainly, more commonly include the thumb and ring finger, but if it happens to that patient, it's more common for them. Symptoms are usually worse in the morning, and sometimes they'll mention to you that they'll need to unlock their finger by straightening it. Unlike the fingers, the thumb sometimes can be locked in full extension. So when you examine patients, if they can't flex their IP joint, a lot of times they'll have trigger thumb locked in full extension. It's more common in diabetics. However, it doesn't mean if you have this, you have to look for diabetes or other endocrine problems. The histopathology, if those of you taking your OIT or tests in the future, again, it's a fibrocartilaginous metaplasia. That's the thought process behind this. The flexors glide at the A1 pulley and this becomes affected. I try to explain it to my patients that the tendons normally go through a tunnel and the entrance to the tunnel is less elastic. So diagnosis, again, within 1 or 2 words, you can hear what it is, basically history. If you're uncertain or if it's a different severity, clinical exam can confirm that. Differentials to look out for. Not everything is trigger finger. Sagittal band, EDCs, sometimes people can report locking or catching. A locked MP joint of the index finger, which will be at the MP joint, can confuse you when you hear locking. And for RA patients, again, avoid A1 pulley release traditionally due to other problems. It's more of a tenosynovectomy or other treatments for RA patients. Pediatric, Josh, I had to include this slide for you. The thumb is most common. It's locked in flexion, and an A1 pulley release is effective. If it does occur in the fingers in kids, always think FDS tendon abnormalities, requiring usually an excision of part of the FDS tendon. So treatment, I think traditionally most people offer patients injections. My technique has changed over the years. I use a 27 gauge half-inch needle with 1 lidocaine and 1 acetylestone. If patients are diabetic, I offer them an injection. I educate them that they may have an increase in their blood glucose for 3 to 5 days, and also mention to them long-term they may not have the effectiveness of the cortisone injections. Surgical release is a effective option as well. Multiple injections, my frame of reference is if it worked for several months or a long period of time, then I consider a repeat injection. So my surgical treatment also has changed over the years, probably for the last, I don't know, 4 years or so. I've not done a trigger release without using a Wallant. For those of you who don't know, it's just a local only method of doing surgery that works, and it's safe and it's effective. It's very useful for trigger finger. Surgical release, whether you make the incision longitudinal, oblique, transverse, it doesn't matter. Retract the neurovascular bundle, release A1 pulley, the palmar aponeurosis proximally, and allow the patients to flex and extend their finger to confirm release. Occasionally, you'll find that someone is still catching or locking. Sometimes it's due to the thickening of the tendon sheath. If the FDS needs a partial excision, the ulnar slip is recommended. But again, doing it wide awake is nice because you can test this and confirm their motion. For the hand therapists out there, the PIP joint does present itself with a contracture for chronic triggering. Also, doing it wide awake, you can assess the ability of the PIP joint to relax once the trigger finger is released. If you note that the PIP still has a static contracture on passive motion, you can educate the patient and the therapist that this may be around for a while, whether it's permanent or maybe it improves with time. Maybe those patients I send to therapy more frequently. Complications, like anything with this surgery, is rare. Usually, if something does occur, it's a superficial wound infection. Persistent or recurrent triggering does occur. Again, it's rare. In these settings, usually in my experience, a patient has not had a wide awake surgery where it hasn't been tested, or have had other methods, including percutaneous releases, which temporarily improves the catching and locking, however, leads to triggering once again in the future. When patients have had a proper release, excising the ulnar slip of the FDS is recommended and usually is effective. Nerve injury is rare. However, again, if you're on a test scenario or in real life, the radial digital nerve of the thumb is the closest, even though the index and small finger digital nerves are fairly close as well. Bowstring theoretically can occur with release of the A2 pulley if one is too aggressive or outside of the zone where they need to release. However, I don't routinely see that. I can't remember a case of that being a clinical problem. So in summary, this is a common disorder. Those of you treating patients with hand problems will see this all the time. Again, it can be effectively treated, whether an injection helps or a surgical release. Your differential by history exam, always remember carpal tunnel syndrome or other pathology or issues that can affect the hand, whether it's deep veins or something else, to make sure, again, one trip to the OR or to your office procedure room will be effective in allowing your patients to improve easily. Thank you.
Great. Thank you, Jason. Maybe I'll just ask you one question. Is it necessary to always identify the radial digital nerve of the thumb when doing a thumb release? Or
So I would say that's a good question, and it's not necessary to identify it, but especially when you're sliding your scissors, I prefer to use tenotomy scissors when doing the release. I don't slide my scissors blindly, or if one uses a 15 blade or something of that sort. I think the recommendation is not to pass anything proximally that you can't see. So if you're going to release proximally, make sure you see the entire area. Distally, I would say the same. See what you're releasing.
Perfect. Okay, we're going to switch gears a little bit to our president, actually, of the American Association of Hand Surgery. Thank you very much, Mr. President, Dr. President, for joining us. Nash Naam will talk to us about the Quervain's tenosynovitis.
Thank you very much, Josh, and thank you, Sarah, and thank you very much the faculty and also the attendees. On behalf of the AAHs, I would like to thank you all. Really appreciate it. So my charge tonight is to talk about the de Quervain's tenosynovitis and intersection syndrome. So we know, all of us know this stuff, but let us just review it fast. The decurvence tenosynovitis involves the tendons of the first dorsal compartment of the wrist, which contains the abductor pollicis longus and extensor pollicis brevis. It's a very common cause of radial wrist pain, and it's the second most common tendinopathy following trigger finger. The credit of describing this entity goes to Fritz Decurven, who is a Swiss surgeon who described this condition in 1895. But we found that there was another French surgeon who actually described it in 1893. So probably should change the name. So we know this, the 6 dorsal compartments, and what we see with decurvence is that usually it happens in the middle-aged individuals. It's more common in women, especially in the postpartum period. And we see it also in not only in young mothers who are really lifting the kids up and down with the radial ulnar deviation of the wrist, but we see it also in grandmothers. And usually symptoms start about 4 to 6 weeks after delivery. Surprisingly, you are seeing more decurvence these days, not in mothers, but in young people who are using especially cell phones and tablets. I think because of the way they hold the tablet, and that will produce some sort of repetitive movement in the area of the first dorsal compartment. But is it really a tenosynovitis? It's not. So that term is inaccurate and misleading because this is not an inflammatory condition. It's sort of a tendon entrapment occurs in this narrow fibroosseous canal. And when the tendon moves back and forth in that narrow segment, it starts to create some hypertrophy and fibrosis and gradually some edema also in the tendon itself. And the histopathology does not show any inflammation. It shows myxoid degeneration. In addition to that, the first dorsal compartment is known to have a high instance of anatomic variation to the extent that only 20% of patients who go to surgery will find that the first dorsal compartment is normal. So we really don't know what the normal is, but the normal is try to find one slip of the abductor pollicis longus and one slip of the EPP. You don't see that frequently. But usually APP is sometimes it's in a separate compartment. We'll talk about that, but could be completely absent in 5 to 7% of the patients. And frequently I see 3 or more slips of the abductor pollicis longus. And here, as you can see, there's some sort of a septum that goes inside the first dorsal compartment and separates the abductor pollicis longus slips from the extensor pollicis brevis, as you can see here in this picture. And that's extremely important to release that septum, otherwise those patients will not improve. If that septum is not there, usually those patients will do very well with conservative treatment. But the presence of the septum indicates that most probably those patients will need surgery. The surprising thing also that in anatomical studies, about maybe 30% of specimens showed the 2 distinct tunnels, but when we do surgery, all of you know that, we see that more frequently, sometimes up to 80%, which indicates that higher percentage of patients with this septum go into surgery. Diagnosis is very simple, straightforward, and most of the time when you go into the room and you start listening to the patient within 30 seconds, you will make the diagnosis in 80% of the time. And usually pain localized to the radial side of the wrist that increases with radial ulnar deviation and also movement to the thumb. The clinical examination is very specific. The first thing you see is some swelling and tenderness over the radial styloid, and you can feel the first dorsal compartment distal to the styloid, and you can feel the tenderness localized there. And the Eichhoff maneuver, which is essentially, most of us think of it as Finkelstein's test. That's not correct. It's the Eichhoff maneuver in which the thumb is clasped into the palm and then the wrist is moved into ulnar deviation. And that was described in 1927. Finkelstein's test is different, that you grasp the patient's thumb and move the wrist into ulnar deviation, and the patient will complain of severe pain. And that was described in 1930. X-rays are usually not diagnostic. Ultrasound can be very helpful because you can see some edema. We see here that the extensor pollicis brevis tendon, there is some edema around it, and there is distortion of the shape of the EPP. And you can increase some fluid inside the whole first dorsal compartment. And sometimes you can see the intertendinous septum if the quality of the ultrasound is good. MRI can be very useful. It's very sensitive and very specific. And usually you see some fluid within the tendon sheath with thickened retinaculum, and the tendon itself becomes enlarged. And sometimes you can see some fraying or tear actually of one of the tendons. Differential diagnosis, probably the most common is CMC arthritis, because the localized tenderness in those two areas, the CMC and the first dorsal compartment, they're like 8 millimeters or 1 centimeter difference. So it's very important that when you're examining your patient is to be very focal on the area of the first dorsal compartment and then compare it to the area of CMC. STT arthritis also develop differential diagnosis and also intersection syndrome and trigger thumb. Most of the treatment in most of the patients can be conservative. Splinting by itself is not very successful. But steroid injections have been found to be successful in 50 to 80% of the patients after 1 or 2 injections. Some of the complications that we sometimes see from steroid injections, such as depigmentation, subcutaneous atrophy, and hepatic necrosis. I have been using silicone for the last 35 years, and I can say that I have not seen a single case of depigmentation. And I would really recommend with catalog and other stuff, I don't work for the company, but really from my own experience, silicone does not really cause depigmentation, especially if you have a dark person or an African-American person. You don't want this depigmentation, otherwise it'll be unsightly. One of the things about also the injection, that if the patient has a septum, it will be very difficult to reach the compartment and the subcompartment. So there was a study by Zingas in which they injected radiopaque dye, and they found out of 19 patients, 13 of them during the injection did not reach, the material did not reach the extensor pollicis brevis subsheath. Please don't try to inject the tendon. I had one general surgeon in a hospital nearby injected a patient twice. The tendon ruptured, so he tried to explore it. He cut the superficial nerve. So he sent me the patient with no tendons and no nerve. We had to do a tendon transfer and nerve grafting. So please, if you're giving the injection and feel some difficulty or pressure, please go back again to really go to the area of the sheath itself. As far as the technique, I really feel that you can simplify the injection if you ulnarly deviate the wrist. You'll find that the first dorsal compartment will be really facing you and will be almost parallel to the forearm. And you can palpate the first dorsal compartment distal to the styloid. You can really feel it. And between your thumb and the index finger, you also squeeze that compartment and you can do the injection correctly. You can really feel the sheath filled distally and proximally. So here's a patient, just the injection, just as I mentioned, sort of stabilize the first dorsal compartment and you go inside. I inject first the local anesthetic and then this silicone. It doesn't matter either way. Does this treatment work? Yes, there are some reviews that show that actually probably injection or combination of injection and splinting is effective in treating those patients. As far as if the patient needs surgery, the technique of the surgery, the best thing is to do a small transverse incision, make that incision shallow so you don't touch the superficial nerve branches. That's extremely critical. And then when you see the sheath, you can divide the sheath along the dorsal side so you prevent volar migration. If your incision is on the volar side of the sheath, it's very possible with flexion, extension, ulnar deviation, that the tendons will sublux volarly. And I found that also it's extremely important to search for subcompartment and see if there is septum, because if you don't really release the subcompartment, the patient will continue to have symptoms. I had one patient, I released the compartment on the dorsal side, and that patient developed dorsal subluxation, especially of the APB. So I started now by doing a sort of a Z-shaped incision in the sheath, this one through the transverse incision, and there's some fraying of the tendon. This is the subsheath. Sometimes I use the chevron type incision if I feel that the swelling is extensive. And in this patient, you can see that I created a volarly based flap and dorsally based flap. So this way, with flexion or extension of the wrist, you don't develop any volar or dorsal subluxation of the tendons. This patient in flexion, the other one was an extension, and the tendons are stable. An alternative surgical technique, I saw this reported in one of the radiology journals, and say ultrasound guided percutaneous release. This review with 35 cases, I would be really scared to do anything not open, because you want to see the superficially the nerve, and you want to be sure that any subcompartment has been completely released. Post-operatively, splint or no splint, it doesn't matter really. I splint them for 2 weeks. The most important complication you try to avoid is the superficial radial nerve. You have to protect it extremely carefully. The second thing, that's incomplete release if you don't attend to the subcompartment and you don't open that completely. And sometimes the volar or dorsal subluxation, and as I mentioned to you, I do now the Z-shaped incision, and with that, you don't really get any subluxation at all. Intersection syndrome is really related to tenosynovitis at the junction of the muscle bellies of the first dorsal compartment tendons, the abductor pollicis brevis, the abductor pollicis longus and extensor pollicis brevis at this intersection, but really, we don't know whether this is really the exact site of the problem or it's in the second dorsal compartment. And usually it's related to friction at the junction of those two tendons between the second and first dorsal compartment. And again, the controversy whether it is exactly at the intersection or it's at the second dorsal compartment, because if we need to do surgery, we release only the second dorsal compartment and the patients will get complete relief. It's also common in certain types of sports activities such as rowing, cycling, and weightlifting. Diagnosis also is not really difficult, swelling and tenderness, and sometimes you feel crepitus, and the patient sometimes describes that to you. But if you do passive or active extension and flexion of the wrist, you can develop that crepitus. Ultrasound can be very helpful. MRI is really not needed, but sometimes patients are referred to us and having all these studies, but usually you can diagnose them before that. Treatment, most of the time, conservative splinting, local injection of steroids. If there is no improvement, then you release the second dorsal compartment, and the results are really very good. So in conclusion, the decurvence tenosynovitis and the intersection syndrome, two of the most common wrist tendinopathies. Diagnosis is not difficult, can be confirmed with ultrasound and MRI if you need to. The treatment most of the time is non-operative with splinting and injection. Surgery is indicated if the conservative treatment is not effective. And with the decurvence release, please be sure that you release any subcompartment and try to avoid the tendon subluxation. And please, 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 you have to protect the superficial radial nerve. That's extremely critical. Thank you very much. Thank you.
Outstanding. Thank you so much, Nash. If you could hit stop share at the top, and we'll move on then to Meredith Osterman, who will discuss other wrist-informed tendinopathies.
Great. Thanks so much for including me, Josh. Let's see if I can get this started. Okay. You see the screen okay?
Yep, you're perfect.
All right, so my charge is to talk on wrist tendinitis that hasn't already been covered. This article in the Yellow Journal is really excellent, written by Julie Adams, that really covers a lot of the topics that I'm going to talk about today. So these are the most common tendinopathies around the wrist and hand. We've just heard about trigger digits, dequervains, and intersections. So my charge is to talk about the rest of them, and we'll breeze through a lot of these. So tendinitis is really not itis. Itis, we think of inflammation, and as already has been alluded to, it's really a tendinosis, which is degenerative changes in the collagen matrix. And it's really more often a chronic injury caused by accumulation of small tears. And I really see this as this imbalance of tendon degeneration and the growth factors and stem cells that are required to constantly build up the tendon. So most of these tendinopathies present very similarly. Patients present with pain that they can localize to the tendon that's involved. Often there's an exacerbation of pain with motion. There may be swelling, there may be crepitus. Sometimes there can be a loss of motion and also weakness. The workup includes clinical exam. X-rays are often normal. However, I always get X-rays with tendinopathies for a variety of reasons. A lot of these tendinopathies are common in patients with inflammatory disease or some type of underlying degenerative changes around the joint. So I think having an X-ray gives you a better understanding sometimes of the etiology of the tendinosis and can also show if there's anything else contributing. But MRI and ultrasound, I think, provide more information in terms of the evaluate for the any intersubstance tearing of the tendon, if there's associated ganglion cysts, and can also show inflammation around the tendon sheath. The treatment themes you'll see are similar: immobilization, anti-inflammatories, cortisone injections, occupational therapy, sometimes activity modification, and at times surgery. Cortisone injections can be very helpful. You can have skin discoloration, fat atrophy. I agree with Dr. Naam that a lot of times if you use celestone or bechamethasone, you don't see some of these complications in the same way that you do with using Kenalog. And surgery is not without issues as well. There can be nerve injury, incomplete release, scar sensitivity, and infection. Often the question will come up when patients present, is this work-related? And there are risk factors that I think don't just pertain to one's profession, but also pertain to patients' activities of daily living, but also their hobbies and interests. So anything with high repetition, high force, an awkward or sustained wrist position, or direct pressure are going to predispose someone to develop these tendinopathies. So let's start with the EPL. So the EPL has a unique anatomy. It takes a sharp turn just distal to Lister's tubercle, and it's encased in a tight fibrous sheath. Very little expansion allowed in this sheath. It isn't common except in patients with inflammatory disease and in distal radius fractures, both non-displaced or minimally displaced distal radius fractures that are often treated non-operatively, and also patients that are treated operatively if there's some type of screw penetration. Patients will present with pain and swelling, often exacerbated with thumb motion. They may have limited thumb retropulsion, which is the real way to test for the EPL function, but they also may have limited extension of their thumb MP or IP joint. And unlike many of the other tendinopathies that I'll talk about, this is one that I'm more aggressive about surgical intervention for early on because there's a high risk of tendon ruptures. I think when you elect to move forward with surgery for a third compartment release, I think you always need to be prepared to do a tendon reconstruction or even a tendon transfer. So for non-displaced distal radius fractures, about a 5% incidence. And really the thought is that the swelling that occurs within that third compartment increases the pressure within the compartment and ultimately alters the blood supply to the tendon, leading to ischemic changes and ultimately attritional rupture. Again, you can't see this if there's malpositioned hardware, such as a prominent screw. So moving on to the fourth extensor compartment, the EDC and the EIP. This is common in inflammatory disease. Patients will have localized pain along the fourth extensor compartment. And you really want to examine the individual finger extension because there can be attritional rupture of the extensor tendons as well. This shows a clinical evaluation of that swelling, and you'll see this tuck sign in picture C, which is really when the tenosynovitis bunches proximally and distally to the extensor retinaculum. And you can see in figure A the amount of inflammation and tenosynovitis within that fourth extensor compartment. Again, here's another visualization of that tuck sign. Often the treatment is anti-inflammatory, splinting, icing therapy, and surgically with the tenosynovectomy, that's done open. This was a patient of mine. To the right of the screen is the hand. And this is the fourth extensor compartment. You can see the swelling within the compartment. And once we opened it up, you can see the rice bodies and the significant amounts of synovitis. And, you know, you want to make sure to do a really thorough evaluation of each extensor tendons because, again, there can be extensor tendon rupture from the amount of pressure that this synovitis causes, leading to an ischemic picture within the tendons and ultimately attritional rupture. This was an interesting article out of China in 2016 that talked about tendinoscopy of the wrist using a shaver to debride the synovitis and the fibrous bands. I have not done this myself. I mostly do it open, but I thought this was an interesting concept. Moving ulnarly across the wrist to the ECU, or the sixth extensor compartment. Patients will present with ulnar wrist pain, and it's really imperative to rule out other causes of ulnar wrist pain. The ECU is closely associated with other ulnar-sided structures, specifically the TFCC, so it's important to evaluate that. And patients will have pain with ulnar deviation and wrist extension. There may be an associated ganglion. They'll often have swelling along the ECU, and you can do the ECU synergy test. And again, the peripheral TFCC is an intimate contact with the ECU subsheath, so sometimes it can be challenging to differentiate the etiology of the pain. This is a patient with swelling along the ECU, and she had 2 large ganglions as well. It's important to be aware of the dorsal ulnar cutaneous nerve when you're releasing this compartment. Again, you can see how swollen that sixth extensor compartment is in comparison to the EDQM, which is sitting more radial here. It's important to evaluate, is there subluxation of the ECU, or is it tendinosis? So it's important to evaluate for subluxation, as the treatment for that is very different than the treatment for tendinosis. And it's also important to make sure you don't lead a patient to develop subluxation by treating someone surgically with a tenosynovectomy. It's important to ensure that they don't go on to sublux afterwards. Moving to the volar side of the wrist, the FCR. The FCR really sits in this hidden tunnel made up of the trapezium. And this cross-sectional anatomy shows that distally, the FCR occupies over 90% of the available space. So it really lies in its own tunnel as well. Patients will present with wrist pain, volarly and radially, often worse with wrist flexion. And you want to look for ganglions. I think this is one where x-rays are really helpful because there's often concomitant CMC and STT arthritis. Patients can be treated with an injection. You want to be very careful of the radial artery, which sits right there, and surgical release. Now, if this tendon ruptures, while patients often will present with some swelling, some discomfort, ecchymosis, they often do quite well because the surgical treatment involves either freeing up the tendon from the canal or releasing it. You can also see this after a CMC arthroplasty, where commonly the one of the slips for the interposition arthroplasty is passed either through or under the FCR. And so it's a relatively common post-operative complication that patients will have some FCR tendinitis or even a rupture after a CMC arthroplasty. Finally, the FCU. This is commonly associated with hydroxyapatite deposition. This is a hydroxyapatite crystals that are deposited either intra-articular or periarticular, and very common in the ulnar compartment of the wrist, along the TFCC or along the FCU. While the shoulder is most common, it's very common in the wrist, and sometimes it can be quite subtle. Diagnosis can be very helpful with ultrasound or MRI, and the treatment is anti-inflammatory and immobilizations. Rarely surgical intervention is needed for that. So in summary, tenosynovitis of the wrist is common. The diagnosis is usually with physical exam. I think that x-rays are often an important component of it, but are usually negative, and MRI and ultrasound can be helpful. And the treatments include splinting, anti-inflammatories, cortisone, and rarely surgical release aside from EPO. Thank you.
Great. Thank you very much, Meredith. So we're going to work our way proximal up towards the elbow, or at least the proximal forearm. And Tom Hughes will talk to us about bicep tendonitis and ruptures.
All right, thanks, Josh. So we're going to talk about biceps tendonitis and ruptures. So we'll talk a little bit about complete and partial ruptures. These frequently present with pain with some sort of eccentric load. People will notice a pop. Perfect timing. Some ecchymosis, weakness, pain with active supination or pronation. And sometimes the diagnosis can be missed or delayed. A lot of people will show up to their PCP a couple weeks later, and then they'll get an MRI, and then they'll show up to your office 3 or 4 weeks after that. Sorry about that. All So on exam, the hook test is a really great test that can tell you whether the biceps is intact or not. You put the elbow at 90 degrees of flexion, you put your index finger at the lateral edge. Sean O'Driscoll basically showed this to be 100% sensitive and specific, and I find that to be pretty close to accurate, better than MRI on exam for a full rupture. Examination for partial rupture is a little different. So basically, you kind of do that same hook test, but then you follow that biceps tendon down to the radial tuberosity, and they'll have pain with palpation there. It becomes more sensitive if you have them pronate their hand, and then while you're palpating, try to have them supinate against resistance, and that's really helpful to see for biceps tendonitis distally or partial ruptures. So the anatomy of the biceps insertion, the short head is a better flexor. It's a little bit more distal. The long head is more proximal, but kind of wraps around a little bit more. The tuberosity is a better supinator. And my partner, Chris Schmidt, is kind of infatuated with this, and as a result, does actually like a double bundle type repair. He tries to repair the two heads of the biceps separately to try and recreate this anatomy. I'm not sure that's clinically relevant, but certainly worth at least understanding the anatomy there. MRI is a great imaging test. This sort of image here, you can kind of see the blue arrow where the end of the biceps lays when it ruptures. I usually don't look at these images. I look at the axial to look for a diagnosis, but I do think it's helpful to see this and just remember that, because when you're trying to find that biceps proximally, remembering just how superficial it is can help when you're palpating. Kind of if you make a distal incision, you're kind of feeling up the wound, and that's where you want to look, right under the skin, right under that subdermal fascia is where you'll see the biceps tendon. Partial tears are a little less sensitive with an MRI, but when you see it, it's pretty specific. So these are some good images here. So here's on the left, you'll see the complete tear. All you really see is fluid where the bicep should be. And again, you'll kind of scroll through these images and look for that tendon kind of coming down where this white fluid is and wrapping around the tuberosity, which we don't see here on the left. Here you can see a partial tear. There's a lot of peritendinous fluid. The tendon is kind of diving down. It would have started up here just subcutaneously, and as you're scrolling through, you would dive down and see kind of wrapping around the tuberosity there. This is a great image and drawing that really shows a high-grade partial tear. So you can see that tendon kind of wrapping around the tuberosity. Here's the tuberosity here. You've got a small percentage, maybe 25% of the tendon intact, just like this cartoon off to the side here. But you can see that the majority of this gray signal here is suggestive of a pretty high-grade partial tear. So a 2010 review showed that non-operative treatment is appropriate for low demand or medically infirm patients. I just turned 50, but if I had my left side rupture, I probably would not have it repaired. So I don't know how medically infirm I am, but whether we fix these or not is still a lot of debate. And I spend a lot of my time talking to patients about why they may consider non-operative options for this, particularly with a left-handed rupture. So, you know, functionally with the biceps, what it's really good at is power supination. Just turn your palm from down to up, which for those of us who put screws in for a living, it's really valuable in your right hand. Your left hand, it is a little less valuable because that's really basically for taking screws out and putting screws in. It's more of a pronation maneuver for left-handed individuals. So I do think that, you know, depending on what you do and what your demands are for this hand and which is your handedness, you may consider non-operative management for these. There's a couple of studies looking at this. Here's one from 2007, 9 patients. The 5 patients that had surgery all did better. However, 2 had PIN palsy. That's a pretty high ratio. I'm not sure I would go to that group. Another study here in 2008, 22 patients did better with surgery. However, 9 of the 10 non-op had good, excellent results. And 2 nerve palsies with surgery. So again, surgery gives a lot of risk that you don't get with non-operative treatment. This study in 2009, my partner Mark Barretts was involved in this. 20 biceps and 18 patients, median follow-up of 38 months. Average supination with non-operative management was 74% of normal. Flexion strength was 88% of normal. Compared to surgical controls, not in this study, but just historical controls, who had better supination strength, but flexion strength was pretty darn similar. So, you know, what I tell my patients is that without surgery, you're going to get pretty close to normal flexion as your brachialis gets stronger and stronger, but that power supination may not really come back to normal. However, the dash for these was 9, and the mean was 14, the median was 9, and the mean was 14, and that's relatively equivalent to what you would get for a normal elbow in this age group. So if the patients decide they want to have surgery, there's historically 2 different ways to go about this. You can do a single incision or a 2-incision approach. I use a single incision approach. This historically has a higher rate of nerve injury. The 2-incision is historically a higher rate of HO and synostosis because you're doing a lot more dissection and bony work posteriorly. We'll come to the way we describe a nerve injury. I just tell my patients they're all going to have LABC numbness and it will always go away. And if you consider that to be a byproduct of surgery like incisional pain, it really removes a lot of the complications from a single incision approach. So if you look at these 2 approaches, when they've been compared, a 2-incision approach is a slightly quicker return to flexion strength. The 1-incision regains slightly more flexion, and the 2-incision had fewer complications because they're considering LABC symptoms as a complication. This meta-analysis showed a 94% success rate with 1-incision versus only 70% with 2-incision technique. The 2-incision technique had a lot higher loss of form rotation and unsatisfactory clinical results because I think the complications with the 2-incision technique can be much more significant, such as PIN palsy, heterotopic ossification, whereas if you have a 13% incidence of LABC symptoms, which I've always found to resolve, then if that's the main problem with the 1-incision technique, to me that is the far more benign complication. The LABC runs right down where you're working from that anterior approach, and when you're retracting for 30-40 minutes trying to get this tendon reattached, it's almost always going to go to sleep for a while. So there are a lot of different approaches for repair: transosseous sutures, suture anchors, cortical button fixation. A lot of people do an endo button or a biceps button. That can be either unicortical or bicortical. Interference screws have been added as well. I really don't like these. I think that the buttons work really darn well, and interference screws have a higher rate of fracture due to the large size of the hole you have to drill in the radial neck at the tuberosity. And that's the combination when some people do a button and a screw, but I really have not preferred that. This is a button technique. This is a bicortical button. Maybe 4, 5, or 6 years I did a similar technique. I don't know if you guys can see my cursor, but rather than dunking this all the way through, we would just basically leave the button here in the intermedullary canal. It's a little bit finicky to get the button to flip, but you avoid any posterior bone drilling and really minimizes the risk of HO and seems to have a relatively good success rate. This is the Spock technique. This is what I've been doing for the last 4 or 5 years. One of our fellows from about 10 or 15 years came up with this, Kerry Turner and Toby Johnson out in California. It's a really simple technique. It's a little finicky, but once you get the hang of it, it's pretty good. So basically what you're doing is you're drilling holes in the tuberosity, as you can see it on this picture on the left, through the radius, and then you're shuttling sutures through that drill hole. If you come back to this, it's a little complicated if you're not thinking about this, but I'll just kind of show on this picture. Your tendon eventually is going to come down between the radius and the ulna, and the sutures are going to be pulled up through this drill hole, and you're going to get a wraparound effect. So this is the technique. So basically you get a shuttle suture through that drill hole. You take these 2 sutures over here that have the little circles drawn around them, and you pass them through each drill hole. So there's 2 sutures through the tendon, 1 each through each hole. And what that allows you to do is to kind of wrap the tendon from volar to dorsal, and you really get the tendon in an anatomic position without making that second incision and putting the PIN at risk. Chris Schmidt, my partner, who's done a lot of the research on the value of that, is that by getting that wraparound, you get the cam effect of the tuberosity, and you really get that terminal supination strength with this without that posterior incision. I really like this. There's no implants. It's really the C of Spock is cost effective, so there's no implants other than the suture, and it's a pretty reliable result. Once you get the hang of the technique, it's not too bad. These are the results. They had 91% of supination strength. They showed no significant difference from the contralateral side in supination peak torque, work, power, or flexion peak torque. So chronic biceps ruptures, these are hard problems. These are people, when their tendon pops and they rupture, and then for whatever reason they don't come in. The options for this are really to push non-operative treatment, and I've done that almost exclusively. Tenodesis to brachialis, I'm not a huge fan of that. It doesn't make a lot of sense to me. And then tendon grafts, which would be my reconstruction of choice for those patients who aren't doing well with non-operative treatment. The series are small, but the results are reasonably good with the tendon grafts. Strength within 3% of the opposite side. Those treated non-operative had some loss of flexion and supination strength. The tenodesis to the brachialis, for me, does not make a ton of sense because, again, that brachialis can hypertrophy just through regular use and become as strong as any muscle to flex the elbow. What the biceps does that the brachialis doesn't is that power supination, and that when that's lost, that's where a tendon graft may be considered. This is a technique using Achilles allograft. Basically, it's a big incision, a big whack, sewing the Achilles all along the anterior surface of the biceps, and then doing whatever repair you prefer for your biceps repair to try and restore the anatomy and use that graft as your distal biceps and regain length. The complications for biceps repair are paresthesias and PIN palsy, heterotopic ossification, radial ulnar synostosis, and anchor failure. When you ask people how often they've seen problems with their biceps repairs, it's always reported as a relatively low number. However, when you ask people how many biceps repair complications they've treated, it's always a much higher number. And so we know that this is a relatively finicky area, and you have to be really careful when you're operating here. Radial ulnar synostosis, Rob Wysocki and Mark Cohen have talked about this. Dean Tyrannos, one of my partners, has also talked about this. They both showed good results with HO removal. They frequently supplemented with low-dose radiation. The dosing of that is really unclear as to what is the appropriate amount, 1 or 2 doses. Biceps tendinosis or partial tearings. So again, as we've talked about all these terms, we use tear is probably the wrong term. It's really a tendinosis or a wearing of that tendinous attachment. Sometimes there'll be occasional onsets of symptoms acutely, but a lot of times it's more of a chronic thing. You'll see changes in the signal intensity, tendon thickens, abnormal tendon contour, swelling about the distal biceps tendon, and tendon defects at the attachment and subtotal detachment. So non-operative treatment for this is NSAIDs, rest, splinting, and activity modification. My bias for this is that non-operative treatment does not work great for this. Having someone wear a splint, take time off from work for 6 to 8 weeks, and then when they go back to work having persistent symptoms is a relatively poor option for a lot of laborers. And I have, in general, found this to be something that needs surgical treatment to get rid of the pain. Ruptures are much easier, I think, to treat non-operatively than partial tears. So I'll frequently get an MRI early to assess how much of the tendon seems to be detached and help to use that with the patient's requirements for their work and life to determine whether we treat this non-operatively and take a chance on that, or whether we go ahead with reattachment. Multiple studies show good results just with surgical reattachment. Basically all resumed previous activity in this one study back in 2001. So in summary, patients can do well with non-operative treatment for full ruptures, although they will have a loss of power supination, which is their most important loss. Surgical repair can restore power supination. The Spock technique is what I like. It's very cost effective and restores the anatomy well. LABC issues are frequent or almost expected, but do resolve. Chronic tears require a large operation, and you might try to push non-operative treatment with those. And partial tears don't do quite as well with non-operative treatment, but surgical repair does help well. And that's all I got. Thanks, Josh.
Great. Thanks, Tom, for that excellent talk on biceps. So we'll move to our last topic, which will be medial and lateral condylitis from, again, my partner, Dr. Mohit Gilotra.
Looks like we're short on time, so I'll move quickly. I have no disclosures relevant to this topic. So we'll cover in the next 3 to 4 minutes the anatomy, epidemiology, pathology, clinical presentation, treatment options, and then briefly in one slide, medial epicondylosis. So we've talked quite a bit already on this webinar, the difference between a tendinitis versus tendinosis, so I won't belabor that point, but this is also in that same category. You know, for the OIT, it comes up that the pathology at the level of the ECRB is a angiofibroblastic hyperplasia, which if you break down the word is an invasion of vascular and fibroblastic elements that then has a predictable degeneration to more fibrotic tissue over time. It classically involves the ECRB, which is deep to the ECRL and superficial to the capsule, but can progress to involve the ECRL and the ECU as well. It's benign, it's self-limiting, the most common reason for elbow pain in adults, and very classically presents in middle age, so especially between the ages of 40 and 60, and very rare to see it in somebody over the age of 70. Repetitive gripping or any kind of repetitive lifting are risk factors for presentation. In addition to the pain and weakness that patients present with subjectively, they can also present with tenderness along the lateral epicondyle, especially just distal and anterior to this point, and pain with resisted wrist extension on examination. The natural history, though, is pretty good. Vast majority of patients have their symptoms resolve in less than 1 year and even in less than 6 months. I have not found imaging to be helpful for diagnosis or prognosis. This is mostly a clinical diagnosis and may be helpful in the rare recalcitrant cases when either A, you have the wrong diagnosis, or B, it's the rare patient that you may operate on. Now, there's a wide differential diagnosis for lateral-sided elbow pain, which, although this is much less common than tennis elbow, still needs to be in your differential. So PLRI, or posterior lateral rotary instability, this can be of a traumatic etiology or a non-traumatic etiology. Traumatic etiology is much more common. Non-traumatic reasons include iatrogenic from previous surgery, potentially from multiple steroid injections, and even as a chronic sequelae of tennis elbow. Pain from a posterior lateral plica, radial tunnel, which presents with symptoms much more distal than the lateral epicondyle. Capitellar OCD can also present with lateral-sided elbow pain, although this is usually in a much younger population. And then radiocapitellar osteoarthritis. Now, the mainstay of treatment for lateral epicondylosis is non-operative, and there's a whole litany of things that you can do. Here's just a short smorgasbord of options, but the list extends much longer than the ones listed here. And those include anti-inflammatory medications, physical therapy, where the mainstay is eccentric stretching, and this can be done with occupational therapy as well. Brace wear using a counterforce strap as pictured here, where the idea is the brace is placed distal to the location of pain, and that it takes the stress off the tendons at the lateral epicondyle. Steroid injection is an option. It can help with some of the short-term pain, but has not shown to alter the natural history. There is some concern that multiple steroid injection in this area can attenuate the capsule and may be a contributing factor to atraumatic PLRI, and there are a few case series that suggest this. Platelet-rich plasma, which has gained popularity, especially in the last 5 years for lateral epicondylosis. There are some studies, especially randomized, double-controlled with appropriate placebo, that show some efficacy, but bigger systematic reviews have not. TENS, extracorporeal shock wave treatment are also options. This was a meta-analysis from CORE from a few years ago, looking at non-surgical treatments as listed in the prior slide to see if it actually improved longitudinal outcomes over no treatment. And the summary of this was that it did not. Now, can it help short-term with symptoms and some return to work outcome measures? The answer is yes. But over the long term, there was no treatment that actually altered the natural history. In the rare patient that fails non-operative treatment, surgery is an option. This can be done arthroscopic or open, and the options include debridement, tenotomy, or even repair. Here's a picture from a JSCS article from Buddy Savoy, who I trained with, showing an arthroscopic debridement and release of the ECRB. In the foreground here, you can see the capsule, which has to be slightly released in order to visualize the ECRB, which is the first tendon you see after the capsule is taken down. And it's this one here with the kind of grayish appearance is the degenerative fibrosis of the ECRB. The key surgical pearl, whether you do this arthroscopic or open, is not to go posterior to the mid-radiocapsular junction, as you can put the LUCL at risk and lead to micro instability. There have been a few well-done RCTs looking at surgical treatment, and here's one of them from Australia. It was an RCT plan for 80 patients comparing surgical excision of the ECRB versus sham surgery, in which only an exposure was done. So this is the best kind of RCT when it comes to surgery, where the control group is not therapy, it's not another treatment, it's a surgical incision without the actual debridement. All patients had a minimum of 6 months of non-operative treatment and 2-year follow-up. There was no difference in any subjective or objective outcome measures. The study was actually stopped after only 26 patients because of a post hoc futility analysis that showed that over 6,000 patients were needed to even potentially show a difference. So a pretty powerful study, and not the only one that has shown this. The one slide on medial epicondylosis is that it's 10 times less common than the lateral side. It involves the flexor pronator mass and often involves the entire common flexor tendons. This can present in throwers in patients that I see, so a UCL examination is critical as the location of pain is very close. Ulnar nerve issues can be common. Prognosis and treatment are similar to the lateral side, and the operative treatment often does not include just a tenotomy, but also reattachment because of the concern for weakness. So for me, these patients, I find it important to show empathy and to say just because that I expect their symptoms to resolve over time, that does not mean that I don't think that they have a bad problem that can be very painful. Education is important on the prognosis, symptom management with ICE, NSAIDs, and brace. I will refer to our physiatry colleagues for ESWT if necessary if symptoms persist. Surgery is an option for the recalcitrant cases after we have confirmed that this is not a psychosocial issue and confirmed on our differential there's no other source of pain. And future directions when it comes to research is what treatment will actually help with altering the natural history and prove to be better than placebo. So in summary, we cover the anatomy, the epidemiology, pathology, clinical presentation, the treatment, non-operative and operative, and the shortcomings of what we have so far, as well as medial epicondylosis. Thanks.
Great. Thank you very much, Mo. And thank you to all of our faculty for joining us this evening, and thank you to all of our attendees that have been with us over the past several months. I hope everyone enjoys the summer and stays safe. We hope to see you sometime in the fall.
Thanks, Josh. Good night.